Rishi from Moffitt Cancer Center, Tampa, Florida, and I'm really excited to give this talk on MR-guided lung SBRT and share some of our experience. Many people who don't know me, I am an alumni of Tata Memorial and PGI Chandigarh, and I'm really excited to give this talk in front of my teachers, friends, and colleagues. I would like to thank the entire Lung Masterclass team and Triranjan for inviting me for this talk. Since I only have 15 minutes, unfortunately, I was not able to take a deep dive into the adaptive planning process in my talk, but I've shared my email. If anyone is interested, feel free to reach out. I have no disclosures. Lung cancer is a success story of SBRT, and it has revolutionized treatment for early stage lung cancer. SBRT, as we know, is a precise delivery of ablative hyperfractionated high radiation dose, typically with BED greater than 100 gray to the target, while limiting exposure to the surrounding normal tissues. Despite lung SBRT being very effective, there are specific challenges in treating these patients, such as critical location, that is central or ultracentral tumor, close to mediastinal structures such as esophagus, trachea, vertebral body, and chest walls. Excessive motion, that is especially with lower lobe tumor, which lead to increased target volume due to greater IGTV expansion to encompass breathing movement. Large tumor, and last but not the least, patient with pulmonary comorbidities. Let's start with a case. This is a 71-year-old gentleman that we recently treated at Moffitt, had 1.5 centimeter nodular mass adjacent to the trachea and esophagus. PET scan did not show any distant disease. EBUS was performed that showed squamous cell carcinoma. So he was staged as T1B and 0M0 or stage 1A2. He was medically inoperable. Just so that we are all on the same page, let's quickly talk about central and ultracentral lesions. So central tumor was initially described by Timmerman as 2 centimeter around the proximal bronchial tree. RTOG 0813 defines central tumor as 2 centimeter in all direction around the proximal bronchial tree or immediately adjacent to mediastinal and pericardial structures, often referred as the no-fly zone. Recently, Nordic Highlands trial defined ultracentral lung tumor as PTV overlapping trachea or main bronchi. They broke this into two definitions of Highlands A and Highlands B. Highlands A include patients who had tumor less than equal to 1 centimeter from main bronchus or trachea, and group B with patients less than 1 centimeter from other regions. So the case that I showed would fall under Highlands Group A. So my question for the team, everyone who is here listening to my talk, is to think, how would they typically treat this patient at their institution? Just to put things into perspective, let me describe the results of the recent Nordic Highlands phase 2 trial. They included 65 patients with ultracentral disease. 39 of them were in Group A, that is less than 1 centimeter from the proximal bronchial tree, and 26 patients with Group B. They treated all patients with SBRT, 7 gray times 8, to total of 56 gray, and they prescribed to 67% isodose encompassing the PTV. So the main crux of this trial that I want to highlight is the toxicity. Look at the figure on the right. So every red dot that you see here denotes a grade 5 toxicity. Just so that we are all on the same page, grade 5 toxicity means death related to the treatment. And they had 15% grade 5 toxicity, most commonly from bleeding, in their entire group, which is very unacceptable. So the main question that comes to my mind and many people's mind is, why was such high toxicity observed in the first place? So our team at Moffitt, led by Steve Rosenberg, who is the director of MRI program, looked into the Nordic Highlands trial patients and plan and wrote an editorial in the JTO. So they prescribed these patients to 6-7% isodose line. So when you calculate, this led to almost like 150% hotspot in a patient with tumor in a very critical areas. That's not good. And there were a lot of heterogeneity on the setup and margins across different centers, with margins varying across different centers from 4 to 7 millimeters in transfers to 5 to 15 millimeters longitudinally. So when you're using such liberal margins around vital organs and treating with ablative dose, we have to be very, very careful. One thing that we don't often realize that both tumor and the normal tissues shift daily with both interfraction and intrafraction treatment movement. This may not be relevant with conventional fractionation, but with Sbrt, especially when we are treating close to vital structures, this shift matters, as we have seen the results of Nordic Highlands trial, which may even cost life. So this is one of our patients for MRI image on fraction 1 and fraction 2. And if you notice here, there have been significant change of the position of airway and esophagus relative to the target. So how do we navigate around this without compromising the dose to the target? One solution is adaptive replanning, or when using an MRI, there's a more fancy term for that called Sbrt, or stereotactic MR-guided adaptive radiation therapy. So what is adaptive planning? It is a change in radiation plan to account for physical changes of tumor or normal anatomy each day. And this gives us an opportunity to personalize treatment for each and every patient. Traditionally, it has been challenging with the use of cone beam CT due to poor visualization, or sometimes we will even do an interim CT simulation and then replan patients altogether. But things have become much more easier and efficient with the use of MR-Linac. So there are two main types of MR-Linac commercially available. One is the Electa with 1.5 Tesla magnet, and other is ViewRay Meridian, which uses 0.35 Tesla magnet. And this is the one that we have in Moffitt. And both of them are FDA approved. Biggest trade-off with MR adaptive radiation is the time, and that it is labor intense. The first thing that we do is patients get an MRI and CT simulation the same day in treatment position. The images get fused. We do the planning and QA similar to a standard IMRT plan. Then the patient comes for treatment, gets MRI on every fraction. We look at the MRI, quickly contour the OARs and the targets, and then check whether this patient's constraints are met and if there's a need for adaptive plan. Once the plan is approved and QA is done, the patient gets treated on a Cine MRI mode. So Cine MRI is nothing but a live MRI in which we can see the movement of tumor and do gating if the tumor goes beyond certain threshold because of the breathing movement. This happens every day the patient gets treated. So the biggest trade-off, as I said, with MRI adaptive planning is the time, and that it is labor intense. So the entire process of patient positioning to the treatment can take up to 50 minutes every day. So the coolest feature of MRI adaptive plan is the ability to do table adaptation to detect anatomic changes and then to rapidly reshape dose delivery to accommodate the changes each day. With the use of MR-Linac, we can also do gating by detecting slight interfraction motion during the beam delivery, which is also pretty cool. So by doing those things, we can certainly reduce the margin to 3 millimeters or even lesser because we are seeing in the real time that the tumor is getting treated or not. This is a figure from Dr. Henke's paper from Washington University, St. Louis. This is an ultracentral tumor, and just wanted to highlight that how actual dosimetry can differ on daily basis. So fraction 1 met all constraints. The same patient on second fraction resulted in violation of hard esophageal and tracheal constraint. So if you look at the DVH, you can see how trachea was receiving before adaptation higher dose, and the dotted line was after the adaptation. Netherlands, Dr. Finazzi's team was pioneer in MR-guided adaptive radiation therapy, and they published the initial experience in Red Journal back in 2019 of 25 patients. And out of them, 92% of the patients needed adaptation. So let me be clear here. We adapt patient during treatment only when we realize that the anatomy has changed so much that we are not able to meet the goals of the either target delivery or OAR constraints. The same group by Finazzi published their clinical outcome in 2020 in Red Journal. They had 54 patients, all central, 30 patients of them was central lung location. Some of them had previous radiation, and 7 patients had interstitial lung disease. So they treated this patient with 7.5 gray times 8 in majority of patients. Some of them got an even higher dose of 11 gray times 5, and 91% of the patients get adapted. But the crux which I want to highlight here is the toxicity. Remember the Nordic Highlands trial toxicity of 15%? How much toxicity did the Finazzi group saw? Was 0. So coming back to our case, what we did for our case for this tumor next to the esophagus and the trachea, we treated this patient with 60 grain 8 fractions with a PTV margin of 3 millimeters. We used the 95% of the target within 3 millimeter boundary to trigger treatment. What does that mean? This means that every day when we do a treatment, we do a cine MRI and we treat the patients only when 95% of the target are within our set goal of 3 millimeter expansion around the target. So out of 8, 7 fractions got adapted, mainly because of the esophageal dose constraint. Recently, we presented our data in Astro. One of our star resident, Mari Sandoval, presented her paper, and she was kind enough to share a slide. So we had 29 patients that were treated with Sbrt. Majority of them were secondary disease. All the patients had central lesions per RTOG, and 86% fit the criteria of Group A Hylas trial. So what we saw was that it was a great local control of 95% at 1 year. But again, what I want to highlight here is we also saw 0 grade 4 and grade 5 toxicity, in contrast to 15% that was seen in Nordic Highlands trial. So just to conclude, the main advantages of MR-guided radiation is that ability to give smaller margin. We can do real-time gating and tracking, and most importantly, on-table plan adaptation to change daily anatomy. The biggest trade-off is that it is resource intense. So we have to be very careful in selecting the patients which has high risk involved with technically challenging treatment, such as patients with a central tumor location who have significant motion, or patient with a significant pulmonary comorbidity, and some patients who have received radiation in the past. So right now we are also in collaboration with the Baptist Hospital of Miami doing a prospective trial, the Lung Star trial. We have patients with both Group A and Group B treated to 50 grain 5 fractions to 60 grain 8 fractions respectively, and it will be really interesting to see the outcome. I would like to thank our entire team at Moffitt, including the MR-guided radiation therapy team, Dr. Rosenberg, Dr. Sandoval, Dr. Sim, and entire residents at Moffitt, all the team, all the physicians, physicists, and therapists, and definitely my teachers, friends, and colleagues at Tata Memorial and PGI. Last but not the least, I would also like to thank the entire team at Masterclass on Lung Cancer and Trunanjan for inviting me for this talk. Please don't hesitate to reach out to me for any question. I've shared my email address and also my Twitter profile. Thank you very much. It's been a pleasure. Have a good day.
Good lecture. Thanks, Rishi. This was recorded. Before we close this session and come to the next session,